Hi, it's Dr. Ray. This is the full lecture video for the introduction to the pelvis and perineum. Here are your learning objectives. So this is basically the information that you would want to be able to describe and explain at the end of this learning module. And so to get started, we just want to talk about where the pelvic cavity is. So you just finished the abdominal region, and you sorted through the intestines, the colon, you sorted through the stomach, you saw the liver, saw all the neurovasculature of the abdomen. And actually, if you continued to look inferiorly, you probably saw the reflection of peritoneum on top of the pelvic cavity. The pelvic cavity is much smaller than the abdominal cavity, and is angled more posteriorly from the abdomen. So you can see the abdomen is almost in a straight line, and then as it comes down this way, the center of it angles posteriorly. And it's going to contain the distal aspects of the gastrointestinal systems, and it also has reproductive organs and organs that are involved in making the female gonad. And so we also have neurovascular structures that are going to supply these organs, and we also have particular muscles that play important roles in supporting the viscera and also roles in moving the lower extremity. So this is going to be the area that is very specifically just the pelvic cavity. And the viscera that sit in the pelvic cavity are very reliant on the bony structures for setting up a framework that protects them and for attachment of muscles and ligaments that also help support the viscera. And the reason why it's so important to understand these relationships is because if you think about all of these viscera, they have openings to the outside of the body. And so they have to course through the floor of this cavity so that they can either make secretions that are excreted or, we're going to end with that. So we have to have a very sort of special and unique situation with the floor of the pelvis so that these viscera can open up into the outside. All right, the functions of the pelvic girdle. So I alluded to some of these if you came to class today, but generally speaking, the pelvic girdle from an anatomic standpoint is going to transfer the forces and the weight from the body above the pelvis. So the spine is going to carry a lot of the body weight down and articulate with the sacrum and also articulate with these coxal or hip bones. And so it's going to transfer the force from the spine and upper aspect of the vertebral column to the lower extremities and the bones of the lower extremity for locomotion. So that is an important aspect. If you don't have the pelvic girdle intact, then it's going to be difficult. You're going to have variations and abnormalities in locomotion or in support of the viscera that weren't there previously. And also just generally, the pelvic girdle is going to be an attachment point for muscles to come off of, and also erectile tissue in both the male and the female. And also some muscles, like example this pelvic diaphragm, is going to kind of make a hammock and suspend the pelvic viscera, but also have openings so that they allow the passage of the fetus. So the pelvic girdle is very important also for connections to muscles and ligaments, as it is really in every place of the body. And so when you look at the bones that make up the pelvic girdle, what you'll find is that there were 3 bones at birth, the ilium, ischium, and pubis, and those bones are going to fuse together to make one hip bone or coxal bone, and you end up having one on each side, and they articulate with each other here at the pubic symphysis. They also articulate with the sacrum on both sides, and then the sacrum is going to articulate with L5, and so there will be another important articulation here. In addition, there is a small coxal bone, which is 4 fused vertebra, that is going to be at the inferior margin of the vertebral column. And so these bones articulate with each other at joints, and they also have fused with each other in development to make one coxal bone. All right, and so for this slide, you can see just a little bit of the fusion line between the ilium, the ischium, and the pubis, and you can see how each one of them actually plays a role in making the acetabulum. So for this slide, I wanted to highlight those articulations. So you can see the 2 coxal bones are going to articulate with each other at this special joint, the pubic symphysis. You can see the sacroiliac joint, which is a little bit weaker on the anterior side than posteriorly because of its ligamentous support. And you can see the articulation between the sacrum and the coccyx. So these are the joints that make up the pelvic girdle. All right, so each bone has landmarks that are important that you want to learn. So it's really helpful. You can tell from a book kind of generally where they are, but it really just doesn't really drive it home until you can hold a bone or look at a skeleton in lab and get an appreciation for these projections. And I started off learning it by just a disarticulated coxal bone, because when you learn the bone's parts and then you start to think about how it sits in life, you can always go back to the beginning with this irregular shaped bone and its very strange projections, and sort of you always have that base. I think if you start learning it with an articulated coxal bone or pelvic girdle, then it's kind of like doing part of the work for you by putting it in anatomic position, and it makes it a little bit harder to retrieve the information. But I think even if that's the case, that's all you have access to, it's still a good starting point. And so the ilium has sort of this big feature, this ala, which makes up this wing, that an iliac crest with the iliac fossa here. So that sort of makes up a lot of the greater pelvis. It has a body. And then another part I had to give you a different view for, because you have to look at it from the medial aspect, is you can see that it has an auricular surface. So this is a surface that actually articulates with the sacrum with kind of some irregular shaped rough surface that gives that joint a shallow amount of stability. So there's not a whole lot of stability there, but it does fit together. And so on this slide set, I have highlights so that you can quiz yourself for the different structures, and it matches up with the coloring in the text on the slide. So other aspects of the ilium that you want to know are the anterior and posterior iliac spines. So here you can see the anterior superior iliac spine here. You talked about this spot already when you discussed the inguinal ligament and its attachment points. But on the posterior aspect of the ilium, you also have a posterior superior iliac spine and a posterior inferior iliac spine here. And then you can see that the ilium is the bone that actually makes this greater sciatic notch here. Okay, the ischium is a little bit, I guess, neglected in the regards to that you can see the pubis, and the pubis plays a role with the inguinal ligament, and we talk about the pubis a lot, the pectineal line, etc., and it also makes up that pubic symphysis. And then the ilium gets to stand out here a lot because of the iliac fossa and sort of the greater pelvis, and you can see it sort of prominently. But this poor little ischium is very important, but it's sort of hidden when you're looking at an anterior view. And if you're sitting down, you're actually sitting on your ischial tuberosities, which is this posterior inferior projection here. And then ilium also has an important bony projection called the ischial spine. So these will be two parts that you'll pay attention to. The other one is the ischial ramus that is going to join the inferior ramus of the pubis. So those are going to be the important parts of the ischium that will become important to you. So learning the anatomy of the bones will also help you identify the greater sciatic notch and the lesser sciatic notch. The lesser sciatic notch is down on the ischium. The greater sciatic notch is up on the ilium. And these notches you can feel, palpate when you are dissecting, and you can put your hand in the pelvic cavity and you can feel them. And they also are important because certain neurovascular structures are going to exit the pelvic cavity by going through this notch, the greater sciatic notch. And then some of the structures that exit are going to come back through the lesser sciatic notch to get access to the perineal region. And so when I was reading through textbooks, I liked one of the explanations that someone made, and it was that if you were going to rewire a house that was already made, like an apartment building, and you needed to run wires from floor 4 to floor 2, it would be much harder to go through the floors to go all the way down, if there aren't holes through the floors, than it would be to go out the window of the 4th floor and come in the window of the 2nd floor. And so that's essentially what's happening here. So instead of going through the floor of the pelvis with neurovascular structures to come out the bottom and potentially mess up with all of these viscera that are opening to the outside, instead the neurovascular structures are coming out of the house and coming on the outside and then coming back through the lesser sciatic notch. So that's why this is occurring. And you'll see that more in depth when we study the perineum. Okay, so the pubis bone is also very important because it has provides a lot of room for attachment for ligaments and muscles and some other important structures like erectile tissue. Here you can see what you would see from an anterior view. Here's a medial view. You can see the pectineal line a little easier. Oh, sorry, it's up here. The pectineal line a little easier. You can see that it has a superior ramus, it has a body, and it has an inferior ramus. And that the inferior ramus of the pubis is going to actually meet up with the ramus of the ischium. And so it's going to make this arch here when the ischiopubic ramus of one side meets the other ischiopubic ramus at the pubic symphysis. You can see that it comes together and makes this cool angle. And so you've probably already been introduced to the tubercle and crest of the pubis when you study the inguinal ligament, because the inguinal ligament comes down here and attaches and then reflects back on the pectineal line that you're looking at. The ligament's not attached here, but you're looking at it at that part. Okay, so now we can see that the bones that come together in the pelvic girdle actually make up this rim that's called the pelvic brim. And so it's a kind of ovoid, it's circular, it's a little bit flattened, like an egg. And essentially, if you had a fetus that was growing in the pelvis, it's going to expand upwards and push up on the abdominal organs and push up on the peritoneum. But this fetus is going to have to exit the body through this pelvic inlet that's made up of this bony ridge called the pelvic brim. And we have other structures like the ureter that are going to drape over the pelvic brim to come down into the pelvis. And so this brim is something that you can palpate and see, and thinking about the bones that make up this brim is important, because if you have trauma, you can get fractures to this circle, and it can crush viscera and neurovascular structures that are just on the other side of these bony encasements. And so you can see here that the promontory of the sacrum is a part of this pelvic brim, the ala or wing of the sacrum. Then you can see that this is where the ilium bone starts, and the arcuate line of the ilium bone and the pectineal line of the pubis are referred to as a linea terminalis collectively. And then you can see the pubic bone, has a crest. The crescent tubercle is in this tubercle, and the crest in this area, and it's going to meet the pubic bone on the other side at the pubic symphysis. So here you can see how it makes a somewhat of a complete surface. The ischiopubic rami of one side and the other, and the pubic symphysis, make a pubic arch, and this arch is important for trying to make an estimation of the size of the pelvis in a pregnant woman. So here you can see, if you could, You might want to measure a true conjugate from the posterior part of the pubic symphysis all the way to the sacral promontory, so you can get an idea of whether the head of a fetus of a certain size is going to pass through a woman's pelvis. And they also measure different types of conjugates that are also useful in estimating the amount of room that a fetal head might have. You can see the ischial spines kind of poke inward a little, and so you might want to know, how far those ischial spines project internally inside the pelvic cavity. So the greater pelvis is that part of the pelvis that is made up of the ala of the ilium and the iliac crest mainly, and it's going to be the part of the pelvis that is superior to the pelvic inlet, or that pelvic brim, you could just say for simplicity. So all of this aspect of the greater pelvis is really not of as much clinical importance as the lesser pelvis, which is between the pelvic inlet and the pelvic outlet. Pelvic outlet being the bony encasements that, for say, the fetal head would have to pass through to get out of the pelvis. So the lesser pelvis has a lot of clinical significance because this is where the viscera of the pelvic cavity resides, and it's where a lot of the important neurovascular structures of the pelvic cavity resides. Here I highlighted the borders of the pelvic outlet just because it helps you think about where these structures start to come together. So here, per se, you might go, what is this? It's a coccyx. So here you can see the coccyx. Underneath this gluteus maximus muscle, you can see the sacrotuberous ligament peeking out here, both sides. You can see the ischial tuberosities peeking out here. And then you can also see that the pubic arch is going to be the most anterior part of this pelvic outlet. And then here, a little game, I have them highlighted. They match up with the names of the structures, so you can test yourself. And that's the actual border of the pelvic outlet. The rest of this is soft tissue, muscles and ligaments, but mainly this tough ligaments and these bones are really relatively immovable, or only movable at a small degree. So I also want to pay a good moment attention to explain the orientation of the pelvic girdle. It actually faces forwards, like the basin is almost spilling out forwards. So in anatomic position, the anterior superior iliac spine is actually at the same plane as the pubic symphysis. And so if you kind of keep that in mind, that's actually how the pubic coxal bones fit in anatomic position. And so when you're looking at medical images, that's the sort of the image that you need to keep in your mind. To go back to the measuring of the pelvic bones and how this is useful clinically, you can see that the posterior aspect of the pubic symphysis all the way to the sacral promontory might be a very useful thing that you want to measure. That's called a true conjugate. Unfortunately, the bladder is sort of in the way of being able to make a really great measurement of that. And so clinically, oftentimes a diagonal conjugate is used so that the clinician can to put his or her fingers into the vaginal canal and feel the sacral promontory, and then they can measure on the anterior aspect of the pubic symphysis on their hand, and then they can get an estimation of the size of the woman's pelvic cavity, or pelvic girdle, excuse me. All right, if you want to see the difference between a male and a female, now this is sort of misleading because certainly pelvic girdles can come in multiple shapes and sizes. So this is by no means a definitive thing. That's why we're having to do measurements and look at the shape of pelvis. But if you do want to see just generally how does an anthropologist tell whether or not a coxal bone or pelvic girdle probably belong to a male or a female, I have a little video for you that you can see on my YouTube channel, and it talks about the differences in the pubic angle and also talks about other differences like the shape and size of the pelvic inlet, etc. All right, so most of the sessions in this week are going to be revolving around the contents of the pelvic cavity. So in a typical male pelvis, you can see that it's going to consist of the bladder, and then you can see the prostate down here, and you can see the seminal vesicles. You can see the ureter cut off and the vas deferens in its course in the pelvis to come down and meet at the ampulla, which is a dilated portion, and it's essentially going to lie just medial to the seminal vesicle. So you're going to have a seminal vesicle, then you're going to have an ampulla, and then you're going to have another ampulla, and then you're going to have another seminal vesicle on the posterior aspect of the bladder. We'll see that when we do the male on Wednesday. And then here you can see for a typical female pelvic cavity, you can see the rectum in this area most posteriorly, and then you can see the uterus here and the superior part or the pelvic part of the vagina, and then you can see the bladder that's situated most anteriorly. Both of the bladders in the male and the female abut just next to the pubic symphysis, so it's just behind the pubic bone. And then you can also see ghosted on the other side of this peritoneum is ovary and a uterine tube. Okay, so we're going to be talking about all of these structures this week, and you'll be able to see them in lab. So I have this PowerPoint. I made this PowerPoint for you so that you can click on the walls of the pelvic cavity and then come back, so that after you've gone through it, you can quiz yourself. And this orientation will help you when you're looking at medical images of patients to think about what structures might be involved in involvement of tumors, hemorrhage, infections, etc. So on the anterior and inferior aspect of the pelvic cavity, that's where you're going to have that pubic symphysis and the ischiopubic rami situated. Now it's kind of cut off, you can't really see the pubic symphysis, but it's important to note that this is going to be the weight-bearing part of the pelvic girdle. So as you can see, gravity is going to come down and push down the pelvic viscera, especially when intra-abdominal pressure increases, and all of this really whole pelvic floor is going to have increased pressure. And luckily, this anterior-inferior aspect is not going to distend as much as this completely muscular aspect where the levator ani is located. When you look at the lateral aspect of the pelvic cavity, you should be thinking about the obturator internus muscle, because it fills up the obturator foramen. Here you can see the obturator foramen, it has a ligament, and then the obturator internus muscle sits on top of that ligament. And the obturator internus muscle has a tendinous arc at its inferior border that's really a thickening of the fascia of obturator internus, and that is going to give an attachment point for the levator ani, part of the pelvic diaphragm, to attach to. When you're looking just posteriorly, and really when you look posteriorly, you're going to see a posterior lateral aspect of the pelvic cavity and posterior medial aspects. The posterior medium aspect is made up of the sacrum and the coccyx. And so that's going to give a lot of sort of bony protection to this part of the pelvic cavity. But it's very thin, so if you did this area when you looked at the vertebral column, you could easily come through from the posterior side and pierce the sacrum, and you find yourself within the pelvic cavity if that happens. Now, if you're looking more posterior laterally than posterior medially, what you'll see is that it's made up of some muscular structures, namely the major structure here is a piriformis muscle. So you can see that the piriformis connects to the sacrum in this wide origination, and then it's going to course outside of the pelvis and come over and insert on the greater trochanter of the femur. And so this piriformis muscle is a great landmark for the inside of the pelvis and also for the gluteal region, because certain structures are going to leave the pelvis above the greater sciatic foramen, and some structures are going to leave the pelvis below the piriformis in the greater sciatic foramen. The posterior lateral pelvic wall is also ligamentous, so not only does it have a muscular component, but it has a sacrotuberous ligament and the sacrospinous ligaments. And so these ligaments attach to the ischial tuberosity and ischial spine, and they are going to really provide good support and good stabilization between the sacrum and the coxal bone. And so the body weight is going to bring, it's going to be in this direction, downward, and it's going to make the sacrum want to spin upwards because of the amount of force that's coming down on this part of the sacrum. So it pushes the posterior aspect with some force, and it wants to ride upwards. The sacrotuberous and sacrospinous ligaments actually stabilize the sacrum and keep it from flipping upwards, and they help attach the sacrum to the coxal bone in a really strong stabilizing way. And then if you look at the posterior aspect of the pelvic wall, I know we saw the sacrum and I showed you that before, but I want to also impress upon you that there are lots of neurovascular structures that are in that region. So the sacrum foramina, anterior sacral foramina, are actually filled with ventral rami of sacral nerves. And so you can see them here, or a few of them, 3 of them here. You can also see the internal iliac artery and internal iliac branches that are going to be coursing around here. The veins have been removed. So then you also have veins, and you have lymphatics, and then you have fascia. And so this area is not really as empty as the sacrum made it look, but it actually is filled up with other neurovascular structures and fascia. And so all of which can be damaged in injuries. So the pelvic floor is made up mainly of the pelvic diaphragm. There are also hiatus or hiati, where you have urogenital structures that are going to leave the pelvis so that they can perform their function. There will be 3 in a female, typical female, and there'll be 2 in a typical male pelvic cavity. Now the levator ani has 3 different parts, and they're just named by really where they connect from. And so clinically speaking, it may not be super important to be able to look and point out the different parts. When you get to the cadaver, you may or may not see the puborectalis. You usually can see, because of its role in maintaining fecal continence, that it usually still has tone and is sort of muscular in the way that it looks. But the pubococcygeus and really the iliococcygeus kind of end up being very, very thin, and by the time you're at the iliococcygeus, it can look more like fascia or a tendon than it really looks like a muscle at all. The coccygeus muscle is going to be between the piriformis and the levator ani, and it originates off that ischial spine. So you usually can find it with your finger and follow it to the coxal bone. And so that one's usually pretty easy to find. It may not be a really thick muscle, but it usually is something that you can locate. So here you can see the coccygeus highlighted, and you can see its course, and you can see that it really is not part of the levator ani. The levator ani is going to be the 3 parts of the pelvic diaphragm that originate off the internal fascia of the obturator internus muscle. So here you can see the obturator, the tendinous arc of the obturator internus, and you can see that all the parts really of the levator ani are going to originate off of this ligament tendon. Sorry. Okay. And so here's just the levator ani highlighted. You can see kind of makes a hammock on the pelvic floor. And you can see the coccygeus more posterior to that, and then the piriformis and their attachments to the sacrum. And the levator ani is going to attach to the other side of the levator ani, and also attaches to a ligament. And it also attaches to the anococcygeal ligament that you can see in this region here. In these figures, I just highlighted the pelvic diaphragm. So you can see where they're located at, and all of the pelvic viscera that are going to be housed superior to the pelvic diaphragm. And it's important to note this because everything that's inferior to the pelvic diaphragm in this region is considered a different kind of body region called the peritoneum. And so we're going to talk about that an entire hour next week. But I just wanted to sort of make a point to highlight that this is the dividing line between the pelvic cavity and the perineal region. So the three parts of the levator ani, the most anterior part, and it comes and joins the other side, is called the puborectalis, and it wraps around the rectum and helps keep this rectal anal angle that is important for keeping fecal continence. And then I wanted to show you another view where you can see the puborectalis muscle sling around the rectum, and if the rectum continues inferiorly here, projects posteriorly as the anal canal, and superior to the puborectalis, this whole region is the rectum. Moving more inferiorly, the next muscular region of the levator ani is the pubococcygeus muscle. So you can see it coursing backwards towards the coccyx, coming off the pubic bone, and it's the thinnest part of the levator ani. And then most posteriorly is the iliococcygeus region of the levator ani, and it's going to come off the tendinous arc of the obturator internus, and also course posteriorly towards the anococcygeal body. The iliococcygeus, remember, being probably pretty hard to find though in the cadaver. The importance of the levator ani is that it is going to help resist the gravity and the pressure that is placed downward from intra-abdominal pressure, and also the just gravity effect on the organs downwards. So the levator ani's tone and strength and continuity is very important for supporting the pelvic viscera. So the peritoneal cavity does extend down into the pelvis, but it doesn't really open into the pelvis. Peritoneum reflects on the superior and some anterior, like for example the anterior aspect of this uterus, aspects of the viscera, and here on the posterior, superior aspect of the uterus, and then it reflects upwards on the rectum. And so here you can see a highlighted part would be inside the peritoneal cavity. There really shouldn't be much in there besides a little bit of serous fluid. And so the pelvic viscera are not inside the pelvic cavity. They are only draped with peritoneum on some of their surfaces. I wanted to especially talk to you about the uterus, the uterine tubes, and the ovaries. They are also draped with peritoneum, but they're draped on two sides. So they're almost encased in peritoneum, and that's why they call these organs, they kind of do lie intraperitoneally, but they're not inside it. They're actually below the peritoneum. And here you can see that the neurovascular structures reach the uterus and the ovaries through this two-layer of peritoneum, which they call a mesentery. But this has a special name, and this is called the broad ligament, is what they call it in this case. Broad ligament is a mesentery because it's two layers of peritoneum, but it has a special name due to its function and where it's located at. The only exception to something being intraperitoneum is that you can see that the ostia of the uterine tubes open up into the peritoneal cavity. And so when an egg is ovulated from the surface of the ovary, and then it's going to go into the uterine tubes for a little tiny amount of time, it's going to actually be floating in the peritoneal cavity. So the draping of the peritoneum makes what's called pouches. Clinically, there are two in a uterus-containing pelvis. There's a rectouterine pouch between the uterus and the rectum, and there is a vesicouterine pouch between the bladder and the uterus. Both of these can accumulate fluid at times when you have accumulation of fluid inside the pelvis or inside the peritoneal cavity. In a non-uterine pelvis, there's only one pouch, and that's the rectovesical pouch that will be between a bladder and the rectum. Pelvic fascia. So all of these pretty pictures that I've shown you has had all of the soft tissue removed, and so you haven't really been able to see connective tissue that lies on the pelvis, but then pelvic viscera. But when you look inside the pelvis, there's a lot of connective tissue there. And we call this pelvic fascia. There's three types of fascia. There's visceral fascia lining the body wall. Visceral fascia overlying the organs. There's parietal fascia lining the body wall, and then there's endopelvic fascia that is going to go between the viscera and the body wall. So those are three different types of fascias that we'll go over. Here you can see the blue line that's on top of these organs. This is visceral pelvic fascia. The blue line that is actually on top here of the abdominal wall on the deep surface is transversalis fascia, is continuous with the lining fascia of the pelvic cavity. We're going to call that parietal pelvic fascia. And this fascia in the pelvic cavity is going to cover structures like the obturator internus muscle, like the levator ani. So it's going to be fascia that is actually on top of these muscles. And then the endopelvic fascia, excuse me, it's going to be fascia that's going to course between the viscera and the body wall. And here you can see peritoneum, but I just want to show you the region that this fascia is going to be located at, called the endopelvic fascia. This is a new view, different kind of figure. It's a coronal view or a frontal section. And you can see this parietal pelvic fascia that comes down. It covers the obturator internus muscle and it covers the levator ani. And then it's connected to the endopelvic fascia, which bridges the parietal pelvic fascia to visceral fascia that's actually on top of the organs. So three different types of fascia named by whatever it is the fascia is on top of. They all play important roles. I'm going to very specifically talk to you about some special terminology that is given to the endopelvic fascia that occurs in certain places because it has a lot of clinical application. The endopelvic fascia that attaches to the uterus is important because it does play a major stabilization role in pregnancy and childbirth. And these condensations are also referred to as ligaments, even though they don't course between bones. But these condensations of fascia can be damaged during childbirth and pregnancy. And so damage to them can cause problems and prolapse in the uterus. And so that's why it's important to kind of understand their role and where they're located at. And the great news is they're just called essentially names based off of what they connect. So like, for example, the pubocervical ligament goes to the pubis and the cervix of the uterus. The cardinal ligament, that being the transverse cervical ligament, is going to go transversely, laterally to the body wall. It is very commonly called cardinal ligament though, so that might be the one that might be a little bit of an outlier. And then the uterosacral ligament goes around the rectum to attach to the sacrum. Now we're to the neurovascular aspects of the pelvis. So the vascular aspects are going to include the internal iliac artery and the internal iliac vein. So you can see those depicted here, and you can note how dense the vascular network is on the wall of organs. So you don't have to know all the names of all of these arteries, but the arteries that you do need to know to make it most simplistic are the branches that come off the internal iliac artery, the main branches that are going to course over and make a blood vessel network on the wall of the organ or plexus. So here you can see the abdominal aorta. The abdominal aorta is going to bifurcate into two common iliac arteries. And then the common iliac artery is going to bifurcate again and turn into an external iliac artery that's going to course under the inguinal ligament and go to the lower extremity, and an internal iliac artery that is going to come down into the pelvis and is going to separate into divisions and then supply branches. The posterior division of the internal iliac artery comes off and courses kind of first. after the internal iliac artery has branched from the external one. And it has three branches: the iliolumbar artery, the lateral sacral artery, and the superior gluteal artery. The superior gluteal artery is sort of the terminal branch of the posterior division of the internal iliac artery. And the main point for the posterior division, most of these branches are going to give blood supply to the parietal aspect, or parietal, aspect of the pelvic cavity. The iliolumbar artery is easy to recognize because it's going to course upwards. The other arteries all go down and back, or down and forward. So the iliolumbar is easily recognizable because of how it moves more medially and moves superiorly from the posterior division. The lateral sacral artery is going to actually course posteriorly and inferiorly along the sacral nerve branches. And so this one you can find if you're looking for an artery that's, it almost looks like it's going down the front of the anterior foramina from the sacrum. And then the superior gluteal artery is the biggest one. And you can see that it's going to be the terminal aspect of the posterior division, and it usually goes between the lumbosacral trunk and S1. Not always, but most of the time it's going to course between those two neurologic structures to exit the pelvis within the superior border of the piriformis in the greater sciatic foramen. Now, the anterior division of the internal iliac artery has a lot more branches. And most of these branches are going to be visceral branches. So they're going to be going to organs within the pelvic cavity, and they may or may not be organs that both cavities have. So some of these are going to be like a middle rectal artery is going to be in the male and the female, but another artery like the vaginal artery, you're only going to find that in the female pelvis. And I think the important thing to remember about this is that they're going to be named after the organ that they're going to. So even if the branching pattern is not the same as what it has in the dissector, it's still going to be called that artery if it's going to that organ. The umbilical artery is a special artery because in the fetal life, it actually brought blood from the fetus to the placenta so that it could get reoxygenated and remove metabolic waste products from the blood, etc. And so there's two. So there's two umbilical arteries, and there was one umbilical vein. If you remember, the umbilical vein brought the highly oxygenated blood. And so the umbilical artery becomes ligamentous in the region of the urachus and alongside, really just lateral to where the urachus is, and you see that in the median plane you have two folds underneath the peritoneum that are medial umbilical folds, and that's where the umbilical arteries were located at. And so you can sort of trace that on the anterior abdominal wall, and you may have already if you've done the anterior abdominal wall in lab. But as you move closer to the internal iliac artery, you can actually find a patent part of this umbilical artery, and there are several branches that come off of it and actually supply blood to the bladder. And so we call those vessels kind of collectively the superior vesical arteries, and they come off the patent part of the umbilical artery. So just kind of a cool anatomic point that makes this artery special. So the anterior division has another kind of special branch, the obturator artery, that courses anteriorly and laterally and goes through the obturator foramen in a small little opening that where there isn't the membranous ligament that covers up the obturator foramen. And so here you can see that going through this canal, obturator canal, and you can see the obturator nerve joining the artery. And then sometimes the obturator artery is actually what they call aberrant. So the obturator artery may actually come from the inferior epigastric artery. Sometimes even more rarely, it can come from the external iliac artery, but you should find in most cases it come off of the internal iliac. The inferior gluteal artery is another branch of the anterior division. And instead of coursing more anteriorly, it's going to kind of move posterolaterally, and it's going to go through the greater sciatic foramen, but inferior to the piriformis muscle. So you can see the superior gluteal artery actually goes through the foramen superior to the piriformis muscle. The inferior gluteal artery actually goes through the foramen inferior to the piriformis muscle. And so it's going to bring blood to the gluteal region. The inferior vesical artery is found in the male. It comes off directly into the iliac artery. In the female, it typically comes off the vaginal artery, and it's going to bring branches to the inferior aspect of the bladder, and also in the male, it's going to bring branches to the prostate. And so you're going to see this course deeply along the pelvic floor. Instead of, it's not going to go back out towards out of the pelvic cavity or anything. And here you can see a different view, and here's the ghosted, the prostate and the bladder, seminal vesicles, ampulla, and you can see the inferior vesical artery bringing blood to all of these structures here in the male. The middle rectal artery, I like this view. It's a really unique view because it's a posterior view. You're looking from the back, and the sacrum has been removed, and the coccyx has been removed. So you're looking at the rectum, and then here's the anus, and this is the levator ani. So really appreciate that. So here you can see the anal column, the anus here, and you can see inferior rectal coming off the internal pudendal artery, and you can see middle rectal artery coming off of the internal iliac and not coursing outside of the pelvis, but rather staying in the pelvis, but close to the pelvic floor and supplying part of the rectum. This can be cut off a lot during dissection. So I do find that, especially if you're splitting the pelvis, sometimes you can cut the middle rectal, and it kind of can be hard to put back together in your mind. But if you do have it intact, it's pretty cool to see. All right, now the internal pudendal artery, like I just mentioned, it does come off the anterior division of the internal iliac artery, and the really fun thing is it actually goes out the greater sciatic foramen. So if you had the ligament attached, this would be the greater sciatic foramen. The piriformis is removed, so you can see it come out the greater, and then you can see that it just sort of wraps around the ischial spine and courses through the lesser sciatic foramen, which the ligament's removed, so you can see the notch. And then it courses anteriorly, and you see it running along the lateral wall of this ischioanal fossa, where it actually is running underneath the obturator internis fascia. So this is the obturator internis fascia, and you can see that the artery actually runs along that wall. It's also called Alcock's canal, and we'll do this when we do the ischioanal fossa. I'll talk about it more at length because you can actually open up the canal and see inferior rectal arteries branch off of the internal pudendal artery. But this artery is going to bring blood not only to the rectum through the inferior rectals, but it's also going to continue anteriorly and bring blood to the perineal region. Okay, in the female, if the pelvis has a uterus, the uterine artery is going to come off the internal iliac artery, and it's going to course towards the floor of the pelvis. So here you can see the floor, and you can see that it's going to kind of run similar, not super close here in this figure because they're trying to accentuate the differences, but the uterine artery comes towards the uterus and the internal os. It actually throws a branch inferiorly to parts of the vagina, the pelvic part, and then it comes up and makes this beautiful plexus of vessels here on the side of the uterus, and comes up here to anastomose or come in and also join parts of the ovarian artery. And so you can see that this artery has a lot of branches, brings a lot of blood to this region. So you do have to ligate this artery if you're going to remove the uterus, and you can see because it passes over the ureter that it can damage. You can damage the ureter if you don't correctly identify it. Now, the vaginal artery also in the Female, that the vaginal artery might be intact even if there's been a hysterectomy, but the vaginal artery is going to come off also course from the floor. Now you notice the ureter is actually going to be between the uterine artery and the vaginal artery, and here you can see it bringing blood more to the lower pelvic part of the vagina. Okay, so for the veins, generally speaking, all right, the veins in the pelvis pretty much follow the arteries, the named ones, and they're going to drain into, the tributaries will drain into the iliac vein, internal iliac vein, and, oops, sorry, it's over here, and just like in the arterial system, where the common iliac is going to branch into an external internal, the venous system joins together. So here you can see different divisions, and they're going to join together to make a common iliac vein. And then the common iliac vein is going to drain into the IVC and then go back to the heart. And I guess with the venous system, one of the things that you want to think about, now there are a little bit more connections with the venous system between the pelvic cavity and the perineum, and also that cancer cells and infections, they can spread through the venous route, and so you kind of track backwards with the flow to see where cancer cells or infections usually more limited by fascial planes. But cancer cells definitely can travel once it gets into the venous system, can travel that way as well as traveling by route of the lymphatic system. Speaking of lymphatics, lymphatic drainage, is a little bit more complex than what I have placed in here, but I tried to just make it a little bit simplified. When you get into, if you go into any specialties and you're looking at a structure at great detail, you'll notice that there'll be little variations in different regions depending on the connections of lymphatic vessels between the perineal region, whether it be the ischial-anal triangle or the urogenital triangle. So you might have a little bit more variation with routes, but you can see the green arrows kind of show you the flow, and it's similar to the venous drainage. You could see these lymph nodes and their general accumulations around the veins. And some of the structures that we have in the pelvis are going to be special. So, for example, the vagina is special because it is going to, some part of it is internal and part of the vagina is external, so it belongs to both the pelvic cavity and the perineal region. And so you're going to have some of the lymphatic drainage be in the more inguinal regions, superficial inguinal lymph nodes, and the more pelvic part is going to follow internal iliac nodes. Other special organs are the ovaries and the testes, because their blood flow, their venous drainage, remember, is going to come all the way up here on the left, join the renal vein, if it's talking about gonadal venous drainage. So the lymphatics are also brought down with them as they descend. And so lymphatics from ovaries, cancers from ovarian cancer or testicular cancer is going to follow the venous drainage. Let's see. Also the rectum, it's not shown on this slide, but the rectum, don't forget, it's a transition zone between sort of the portal system, venous system, and the systemic system. And so at that superior and inferior switch in the rectum is where you're going to have that also switch in venous drainage, innervation, blood supply. And so cancers that are in the anal canal, let's say, are going to be a completely different spreading via lymphatic route and venous drainage than cancers or infections that are, say, in the superior part of the rectum, which is going to follow more inferior mesenteric nodes. Okay? All right, innervation. So just like in other areas of the body, we have different kinds of innervation. So it's not a necessarily easy question. When you ask yourself about innervation, what you should ask is, how does this kind of innervation get to this particular body part? So we're talking about the pelvis. So you might want to to ask yourself, like, how does somatic innervation? So somatic innervation, like if you have just general somatic efference. So if you're bringing motor action to muscles, like for example, the levator ani or the obturator internus muscle, you're going to have branches that come off of the sacral plexus. So you see the sacral plexus, the lumbar sacral trunk comes down and joins that to make some nerves, like for example the sciatic nerve. But there are other nerves that just come off of the sacral plexus, and there are also small muscular branches, not pictured here, that are going to bring innervation to the coccygeus muscle, levator ani, and the obturator internus muscle. Obturator internus muscle actually gets its innervation in the gluteal region through the nerve of the obturator internus, still coming from the sacral plexus. If you're asking yourself about autonomic innervation is twofold, as it is in most places. There is parasympathetic innervation, and most of the abdomen, parasympathetic innervation comes from vagus, but in the descending colon, starting at the descending colon, parasympathetic innervation switches over, right? So it's not going to come from the vagus nerve anymore. So we have some sacral splanchnic nerves that are going to, pelvic splanchnic nerves that are going to bring parasympathetic innervation from S2 to S4, and is going to actually allow parasympathetic innervation to reach this aspect of the pelvis and the descending colon. And so sympathetic innervation is going to come from two places mainly. One of them is the sympathetic train that extends all the way down to the end of the sacrum. So here you can see it extends all the way down to the ganglion impar where it meets in the midline. And so here you have ganglia, which are the cell bodies of sympathetic nerves. Sometimes they synapse further up the chain, but regardless, you can see the gray rami communicante that come over and provide sympathetic innervation to these sacral nerves, and they can be carried to their destinations. Another way that, I think I have it on the next picture here, another way that sympathetic innervation can get down into the pelvis is through extensions of these nerve plexuses that sort of already exist in the abdomen as they continue down. So here you can see inferior mesenteric ganglion here, and you can see the superior hypogastric plexus, and you can see that the hypogastриc nerves, a left and a right one, are going to descend over the pelvic brim and make a new plexus called the inferior hypogastric plexus. So this plexus has nerves that came from above it, but it also has new nerves that are contributed from the sympathetic ganglion in the sacral region, and also from the pelvic splanchnics for parasympathetic innervation. And so these nerves also hop on blood vessels to reach their destination, and you may see some of them around blood vessels in lab. So the autonomic innervation, you might wonder, what are they doing in the pelvic area? And we're going to go over a lot of specifics when we talk about the specific male and female organs. That might help you. But generally speaking, it's always going to control blood vessel dilation and contraction. So the sympathetic nervous system is going to contract the vessels and restrict flow. Parasympathetic is going to allow for engorgement where it's needed, especially in the erectile tissues, which is kind of new to our discussion on autonomic innervation. Don't forget, we also have the distal aspects of the urinary and digestive system in this area, and it's kind of interesting. So the parasympathetic and sympathetic also play a role in helping to inhibit tonic contraction of the internal urethral sphincter that exists in the male. And so it's also needed for relaxation to allow for defecation and urination. So this autonomic system plays a role even when you're trying to voluntarily do something like urinate or defecate. You still need this innervation, this autonomic innervation interplay to take over to allow for relaxation of sphincters. And so this is sort of just supposed to be somewhat funny. It's my attempt at a joke. And so generally speaking, most of the time you need parasympathetic to let it go, to defecate and to urinate, but there is a big exception, and that's ejaculation. So erection of the erectile tissues and filling with blood, you need a parasympathetic to dilate blood vessels and allow blood to come into the cavernous spaces. But for ejaculation, actually need sympathetic response to promote the contraction of the smooth muscle in the walls of the glands and in the ducts to forcibly expel semen from the male urinary tract. Okay, and then usually talked with autonomic innervation, but nowhere is it really related to its function, because these nerves are completely separate from parasympathetic and sympathetic, because those are efferent signals, those are motor efferent signals, and GVA is afferent visceral signals. So why do we talk about them together? We talk about them together because GVAs oftentimes follow autonomic routes to get back from their destinations, because a signal is going back towards the central nervous system. All of these neurons have their cell bodies and dorsal root ganglion. And what I wanted to point out here is that the traveling back of GVAs from organs that are in the pelvis are going to follow both the parasympathetic routes, because we have these pelvic splanchnic nerves, and they're also going to follow the sympathetic routes. There's lumbar splanchnics, there's sacral splanchnics, there's nerves coming out of the sympathetic chain, and so GVAs can actually follow both routes in the pelvis, and as you have been studying along the lines, that's not the case usually in other places, so kind of special here. And then lastly, what I'm going to end you on is something that we're going to pick up next week, and I'm then going to give you an orientation, all the details that you really need to know as a clinician to understand the anatomy of the perineum. So we've been talking about the pelvic diaphragm. We've been talking about where the pelvic diaphragm is located at, what is it made out of, all of the viscera that sit on top of and rely on this pelvic diaphragm, so levator ani, the coccygeus muscle. And then next week, we're going to talk about this other region, everything below that, which we call the perineum. And so what this is going to entail is all of the external genitalia, and also the ischial-anal fossa, which is the area around the anal canal, which is filled with fat and some nerves and some vessels, all of which you've already been introduced to, luckily. So we're just going to put together these pieces and follow up our discussion on the pelvis and perineum. And so in anatomical position, you will see this region more like this, and you'll see it more like this in lab, because it's a lot easier to approach the perineal region and appreciate it from this section. When you look at it in a sagittal section, and this would be the space here, it actually maybe not so bad for medical images, because you can see that pelvic diaphragm and you can get an idea of where you're located at. But if you're trying to do an examination on a patient, you're probably going to be doing the examination from this position. And so it's good to kind of get your bearing on, so like, for example, here's the coccyx, here's your ischial tuberosities, here's the pubic arch, and sort of get that laid out in your mind so that when you're doing an examination, you know what the underlying structures are. If someone has swelling or pain or lesions, you know what is going to be related to that area. Okay, so that's a little bit more than just an introduction, but like I said, I'm trying to give you as much as I can up front so that you can follow through with all the details as you feel like you want to learn them, and I don't want to hold back too much, but I couldn't do all of this in an hour, and so I wanted to give you the choice on whether you want to watch an abbreviated version and read the details, or if you wanted to watch the whole thing. Okay, so if you have any questions or comments, feel free to email me, and I will see you later.